I'm here with Fiona Moore, who's the Clinical Director for Trauma in London. Fiona, there have been a number of significant changes in the management of major trauma nationally in England, and London's very much been at the forefront of pioneering those changes. Can you tell me a little bit about the background behind these?
Well, the background, Jonathan, is that many reports over 20 years have demonstrated that major trauma in this country is really poorly managed. And for many occasions, nobody's done anything very much about that. But the NCPOD report that was published in 2007, the Trauma Who Cares, came to the attention of ministers, and a national trauma czar was appointed, Professor Keith Willett, and he's been taking forward the National Trauma Initiative. Now in London, we were, I guess, lucky because Healthcare for London had implemented Lord Darcy's report and taken forward a framework for action. And part of that was the initiative on major trauma and stroke. And as a result of that, we've got the London Trauma System, which consists of 4 networks, each network having a major trauma centre and a number of trauma units. And each major trauma centre is responsible for its networks and the trauma units within it. Okay. Now, 3 of those networks went live in April 2010, and the 4th went live earlier this year on the 10th of January. So now we have 4 major trauma networks in London. Okay. Now,
I work in a trauma unit. I work in intensive care, but I frequently down in the emergency department in the trauma unit. There are situations where I could see myself having to manage a major trauma patient who ends up in my emergency department. They may self-present, they may have been triaged initially and found to be fine, but they've subsequently deteriorated. They may have had a life-threatening airway problem that needs imminent treatment in the nearest emergency department, or from time to time they may have simply been under triage. If they arrive in my department, what should I do?
Well, you need to decide in conjunction with the trauma team leader in your unit whether you've got the capabilities to deal with that patient or not. Okay. And essentially, if you have not got the capabilities, and that may be that you don't have the surgical capability or anaesthetist sufficiently senior to undertake the case, or you don't have an available theatre, then you can transfer that patient to the major trauma centre. Okay.
If you have some facilities, for example, say the patient's bleeding and you have the general surgeons on site who feel they can do damage limitation surgery, is that an appropriate route to go down?
I think so. I mean, you could imagine the situation where you have a patient with a ruptured spleen that can be relatively easily dealt with within 30 minutes within your trauma unit, and it would be entirely acceptable to do that. If, however, you don't have those capabilities, then the major trauma centre, your local major trauma centre, has the responsibility to accept that patient. And so the trauma team leader at the trauma unit needs to be in close contact with the trauma team leader at the major trauma centre.
And are there any exceptions to these, or is this all trauma patients or any particular specific groups of patients that would not follow this pathway?
Well, isolated head injuries do have local protocols to follow, so that would be excluded.
Okay. Now, a number of, the trauma tree that we talk about, the algorithm that we use to direct these patients arriving in trauma units, a lot of the endpoints of these branches lie with the major trauma centre. How do we contact the major trauma centres? What's the sort of routine we should go through in order to contact them?
Well, you should contact the trauma team leader at the major trauma centre, and that individual will be easily contactable. It's a 24/7 role. Okay. So it's a direct person-to-person.
And consultant-led role, you should point out, is that right?
Yes, one of the absolute requirements to be a major trauma centre is that you have a consultant-led trauma team 24/7. Okay. So that individual will be available to answer your telephone call, to liaise with you about what the issue is at your trauma unit, and to facilitate the transfer.
Okay, and if we find, again, from the trauma unit perspective, if we find we're in a situation not with an acute patient, but we have problems either afterwards or in anticipation of patients coming in, if we have problems that we raise or concerns we raise, can we contact the major trauma centres in those situations?
Yes, absolutely.
Okay.
Because even if a patient were being transferred, say 4, 8, 24 hours later, it's often appropriate for them to go straight through the emergency department and to be re-trauma called when they arrive.
Fiona, you're also the medical director for the London Ambulance Service. If I have a patient, a major trauma patient, and I need to transfer them to the major trauma centre, obviously I want them to get there as fast as possible, but what's the official line in terms of how I book that with the ambulance service?
So you need to request a critical transfer, and the form of words is quite important.
Yeah.
And that would be a phone call to our emergency operations centre requesting a critical transfer.
Okay.
And that will ensure that the next available ambulance will be sent to you.
Okay.
And we would attempt to get them there within 8 minutes, but certainly within a maximum of 15 minutes.
Right. So just to sum up, as a trauma unit consultant, probably the most important thing I need to do is make sure that we have access 24 hours a day to the secondary transfer protocol for major trauma, which presumably should be adapted locally so we have the local major trauma centre numbers. Is
Yes.
that right? Anything else I should be thinking about?
I think you need to remember that the trauma unit has the responsibility to ensure that the patient gets safely to the major trauma centre in terms of the accompanying team.
Yeah.
The ambulance service cannot guarantee that you will get a paramedic crew,
Right.
so you will need to provide the staff to go with the patient.
Right.
I think it's also important that there's a debrief once the patient's got to the major trauma centre, so that if there are any lessons to be learned about that case, then they can be shared between the trauma unit and the major trauma centre.
Fiona, thank you very much indeed. It's been great chatting with you.
Thank you.